So welcome everyone to a new episode of Prostate Cancer Prostate Diseases Journal. We'll talk a little bit about BRCA mutations in prostate cancer. I'm here with Dr. Stroomberg, who will actually present us his paper recently published in Prostate Cancer Prostate Diseases Journal. So please, Vincent, introduce yourself. Tell us where you work, what are your duties.
Yeah, good day. My name is Hein Stroomberg, and I work in the Copenhagen Prostate Cancer Center in the University of Copenhagen Hospital. And I'm a full-time researcher. And in my position, we do a lot of studies, obviously, on prostate cancer focused, but we're part of the urological research unit, so we have focus also on other cancers. But in this case, this falls very close to me, translational science.
Okay, very good. So tell us a little bit, what was the input for developing this research?
Yeah, so this started a long time ago. I'm not sure how familiar you are with BRCA testing in general, but it's not a very straightforward thing, but it's been done in cascade setting from ovarian and breast cancers. And in this cascade setting, you would test the family members of women, in this case, that are affected by BRCA found through breast cancer or ovarian screening. And then they asked, the clinical genetics asked one of the professors of our unit, do you want to see these men in order for potential prostate cancer screening? So this is how it all started. The ball started rolling somewhere around 2013. And I'm not sure how much you know about it, but it was quite an uncommon thing at that time, BRCA screening for prostate cancer. There was not much known, but our professor saw we have quite a large tradition in biomarker research in our unit, so we've also known about what BRCA is involved in sort of pathway-wise. And then he said, yes, we are interested, and we will set up a prospective study within certain frames to look at this conundrum.
Okay, so for the residents, because some of our followers are residents, can you just briefly summarize what is exactly the role of BRCA in prostate cancer diagnosis and management nowadays? What should the youngest know about it?
Yeah, so I think first of all, it's good to know what is BRCA. It stands for breast cancer-related antigen gene, but it's not actually a breast cancer-related gene. It's a homologous repair deficiency gene, which means that in the cell system, it was a part of a system that checks whether there's mistakes in your DNA. And when you have some of these so-called pathogenic mutations or likely pathogenic mutations, this system is disrupted to some extent. So you're more likely to get mutations. And from this, there's the hypothesis that you can get more cancer. That's why it's been initially found in breast cancer, but we also find it in prostate cancer. The role of BRCA is still very much unknown. There are some studies, including ours now, that have done some screening setting that have consistently shown that there's an increased risk for prostate cancer compared to the background population. And based on that, we say, yes, it's if you find men with BRCA, it's good to start following them in certain intervals. But what to do with these men is still largely unknown. We don't know how to specifically treat them differently than other management. We do know that in a very late stage, you can target this pathway with PARP inhibitors, but this is very far castration-resistant prostate cancer stage. So this is not actually well known what to do with these men early on. This is why we also are very interested in this topic.
Okay, so tell us a little bit more. Let's get a little bit more into your manuscript, into your paper. So what did you do? What are your main findings and the limitations of your paper?
Yeah, sure. So from 2014 onwards, we've prospectively enrolled men with BRCA mutations, pathogenic BRCA1 or 2 mutations, into a screening program where we actually biopsied men at low age-specific thresholds. So we specifically chose to go below the normal PSA thresholds because we were suspecting that it might be a different kind of biology behind prostate cancer. And these men at these age-specific thresholds were offered biopsies, and that we've analyzed. So we're roughly, after 7 years, we had 37% that had got a biopsy, which is pretty high in case of a general setting, based on these low age-specific thresholds. And we've find a lot of cancer. Yes, we do find a lot of cancer. In the BRCA2 specifically is 11 times higher than the background population, age-matched background population. But also in BRCA1 we see 5 times higher incidence of prostate cancer. And we do find these prostate cancers in a very low stage. So we find them mainly in Gleason 6s, which is one of the purposes of our early detection, because we believe that there potentially is a smaller curability window within these BRCA patients due to this inherited mutational drive. And in our studies, we have also defined that we would like to offer radical prostatectomy to these patients in an early stage where you normally would be eligible for active surveillance, because we were worried about this potential different curability window. And even though we don't have that many prostate cancers in our cohort yet, we did see in our follow-up that if you do treat with radical prostatectomy, the biochemical occurrence is much higher than expected. So we have a biochemical occurrence rate of 22%, which we after, what was it? To check. After 4 years, and if we took the MSKCC nomograms, we expected like only a 5% recurrence rate. So it is a lot higher. So there's something, we think there's something going on, biologically speaking, in these patients, which would justify an earlier treatment option for these men. Our follow-up is not long enough for prostate cancer specific death, so we couldn't elucidate that.
Yeah, but I think that it's a big result. I mean, it's a big difference between a normal population. So probably, for sure, we cannot inherit what has been done already for actually for breast cancer, but we can suppose that we might get similar results. So I mean, from the literature we have nowadays, I think that we truly can believe that these patients have to be treated differently when compared to the general populations. Do you agree?
I would say there's a good equipoise for enrolling these patients into trials where you actually treat it more rapidly than we normally would.
Than the other ones. Yeah, and so what do you think that are the gaps in this setting? What do you think that that actually it's missing nowadays?
Well, so our biggest limitation is that we didn't have pre-MRI in all of them due to we started enrolling pretty early. But one of the big gaps is like, how does MRI perform in these relatively young men? Because we don't know that. We get some insights from the screening studies performed currently in the general setting, but these are young men. They have small prostate volumes. How does MRI perform in these men is a big question. Also because they seem to, if they are on a radical prostatectomy specimen, quite multifocal, which might act differently on MRI scan than the classical prostate cancer patient that is 65 years old. Also, I think, well, we touched upon that briefly, like how to manage these. It's still very largely unknown. Like we enrolled for close to 10 years and we only have close to 400 men. So it's not a huge group of men that we're talking about. But in all these BRCA 1 and 2 patients, but it's really unknown what to do differently. So that's a big unmet need. And I think that we need trials for that. And unfortunately, because it's a small group, we need this probably to be multi-national trials, which are sometimes hard to run.
Yeah, I agree with you. It's it's like starting a rare disease actually. So probably, and so in that setting, do you think that AI, artificial intelligence, may help us by using data from linking data that we may not be able to link to such, the big opportunity of AI is that it may find different links with different diseases that may be normal regression or associations that we use in statistics may not see. Interpretation of big data. What do you think do you think it is a role, or we are just too early to actually use AI in this setting?
Well, AI is actually not really well known to be good at elucidating what's going on. It's good at predicting. It's outperforming in some studies prediction models that we classically use as Cox regression, because it loosens up, for example, linearity and makes cutoffs that we can't see ourselves, that we otherwise have to test manually. That's very hard to do in Cox regressions manually, but the black box phenomenon is still mainly there. So if you want to elucidate biology, I think you will still sort of be have to rely on some sort of traditional statistic and traditional research methods. That being said, I do think AI has a lot of opportunity also. For example, it's not easy to interpret a BRCA mutation. we have a close collaboration with the clinical genetic department. You need very good clinical genetic departments to interpret all these mutations. There have been previous problems regarding this in studies where they actually took non-pathogenic BRCA mutations and in this case started screening, and this is harmful for these patients because they're actually not patients. So in this case, to interpret these genetic results, I think there's where AI can really help, because this might be streamlined. Prediction modeling, yes, but then we need to know the biology a little more.
Okay, so just to explain, because you know,
I need to change my battery because it's not getting my battery. Computer's going out. 1 second.
Don't worry.
I thought it was in the charge already.
Don't worry.
But now it should be charging. Otherwise, I fall away.
Don't worry. Don't worry. As I told you, this is not a problem. As I told you, that's a good thing of not being live, or even though it's the same thing. So you know, you said something that I think it's very important, and I think I would like you to explain to the ones that are not very familiar with AI, actually what the black box means, because I think that's one of the main problems of, especially of new NLP models. So can you explain to the ones that probably don't use AI why the black box phenomenon is?
Yeah, sure. So in a classical Cox regression, you're putting your in your model, your clinical data that you have decided how it is. Recent grade groups is a good example. ISO 1, 2, 3, 4, 5. You put it in yourself. But also PSA, you put it in linearly, or you make it exponential, or maybe some cutoffs that you decide yourself. The black box of machine learning, you have a lot of different algorithms, so like random forest modeling. For example, if you just feed it the data, it will start making cutoffs by itself. And you don't really know where they make the cutoff. And it might be in different subgroups that they make different cutoffs. This gives a lot of flexibility and therefore also a lot of prediction, especially internally. And there's methods to make it also externally even more valid. But these cutoffs, where it puts it and how it puts it, and when the model itself decides where to put PSA in a division, you have no control over. That's the machine learning. And how that affects the whole model, you don't know. And that's a black box.
I agree. I agree that this is an important phenomenon, because when you go through the literature on AI, and I think that this is maybe the ones that are hearing us can try to do it. Actually, when you ask a normal ChatGPT app, whatever it is, the same question twice in 2 different days, it may gives you a completely different answer, or maybe a similar answer, but not the same answer. So that makes a little bit of confusion when actually evaluating the accuracy of these models. So especially the new ones, probably the old models with random forests or artificial neural networks were a little bit more linear as models. Now the new ones are probably the black box. It's complicated to understand, and it's also complicated to understand how it got to that conclusion. So I think this is something that probably the ones actually working on AI should solve to improve the actual models that are available. So we were talking about you have a close relationship with your genetic department. So you know, in our journal we have a recent paper on genetic board, and so I wanted to know what you think about it. They do it virtually, actually, but what do you think? This is something that we should have in all the MDTs? Do you think that it's something that it might be not that useful? What is your opinion on that?
I think it's coming. We're in the early stages of genetic decisions in prostate cancer, like both in screening but also in treatment. And the interpretation of all kinds of genetic material is very, very complicated. I think most people will probably know the difference between germline and somatic mutations, but all the allele frequencies, the types of mutations you can have, or not even mutations, or structural variants, that becomes extremely complicated, and therefore you just need experts. You can't rely on that every MD knows everything. And I think It's our experience that it's a very good collaboration. They have their specialties, we have our specialties, and bridging those is vital for us to help patients and to send them on. Also, maybe they need family testing. Maybe we, as prostate cancer researchers or clinicians, we don't know what other mutations are important for other cancers. That's not our specialty, but they will know. That's their specialty. There's other kind of classic mutations that are used for other cancers to screen, which is not our field to know, but you need those men and women from the other departments to help you in understanding these changes. So it's vital to come. And also for treatment, like certain mutations are not the same as the others. Certain mutations are more pathogenic than others. Some are not clinically relevant at all. But if we just take mutations as a starting point to start treating, it can become a mess. And also that can potentially harm patients if you start treating them for, let's say, olipara, but there's no proven benefit for that kind of mutation. That might be harmful. We don't know, but it could be. And that's something where you have to be really careful with this sort of detailed information like genetics.
Okay, very good. I think that I completely agree. It's obvious that you need experts in this field, that it's not actually manageable by a normal urologist or oncologist. It's something completely different and as you said, very complicated for the common specialties that are involved in an MDT. So to conclude, actually, what are the next steps of your research? What do you think that you should actually explore in the next future?
Well, we will continue enrolling patients with pathogenic and likely pathogenic BRCA1 and 2 variants, and we'll keep following them up, seeing about longer follow-up, more patients with prostate cancer. That's definitely something we'll keep on enrolling. We're also trying to expand on other kind of mutations that we think are interesting and make biological sense to enroll them in similar trials. We have large prospective studies rolling in more comprehensive genetic testing, which will inform these kind of prospective screening studies that we'll do. I think there's a lot to learn. There's also a lot to learn about from GUSs, even though they've not been shown to be that good in predicting mortality, but there's a germline component to prostate cancer that we're yet to understand, and these can be a big focus to help with all the screening and debates that we've been talking about.
Okay, thank you very much. I think that we've been through the main aspects of BRCA mutations. I think we have also gone a little bit deeper on the problems of AI. So I really thank you for this very nice podcast. I think that especially for the young urologist, it's important to know this part of genetics, which may be not a common part of urology or oncology training, meaning that it's very specific, and as you said, it's very new. So I really thank you for participating, and I hope that you will consider prostate cancer, prostate diseases for your next papers on the subject or on other subjects on prostate cancer. So I thank all our followers on YouTube and on Spotify for following us, and see you on the next episode. Thank you.
Yes.